Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Start off with a bang, huh? Trump administration is testing our democracy, and it was ordered to remove CDC and FDA websites, which were taken down because they were frightened by Trump. Uh, so it's interesting to see how long these changes and this battle between the administration and the court system will go on because it's an interesting test of our democracy. So, any other comments about the unsurprising efforts of Trump to uh, revolutionize everything?
I had a comment that the effect of closing down the CDC and the FDA, I think that's relevant to our health concerns because he's putting a political agenda on top of our health. So I'm very concerned about that. I lose sleep over that.
Well, you'll be losing a lot of sleep because he's only just begun. So it's going to be interesting in the battle. Darryl?
Yeah, at the top of the screen it says the FDA removed pages recommending the inclusion of more women in underrepresented. I'm sorry, go down a little bit. Yeah, right there. Uh, recommending they removed the pages that recommended the inclusion of women and underrepresented groups in clinical trials. That's kind of important. That's taken us out of the mix.
Well, that's his intent. That's his intent. So, and he's going to keep at it until he can accomplish it, unless the court restrains him. And I think the Secretary of Health is going to be Kennedy, is going to be doing similar things along the line. So it's only just begun. It's interesting. The next 4 years is going to be traumatic for all of us. Any other comments? Okay, well, I think there's nothing that we don't already know, but we just have to be aware of what's going on and try to support uh, the democratic process. Okay, let's go to the next article, please. This is an interesting observation that the liver disease, which is now increasing, the metabolic liver disease is increasing, the non-alcoholic liver disease is increasing. Of course, we do have the glucagon derivatives that are now capable of treating it. In the past, we actually had no way of treating a metabolic associated non-alcoholic liver disease. Now we do have it, but the expectation, as you see by this article, is that these metabolic associated liver diseases that are non-alcoholic are increasing, and one of the reasons I guess it appears to increase is because hepatitis C, which used to be one of the commonest causes of liver disease, has now been treatable and curable by medication. So as this burden increases, one of the things that is positive is that we do have a medication that will treat it as well. And that's good to hear. Of course, in the past, the treatment of diabetes and control of the blood sugar was one of the ways of treating it. And then when it got to a stage where that didn't do any good, then liver transplantation became the treatment of choice. And so this increase in liver disease is something that will cost many lives and increase the need for liver transplantation. Any comments about this as we have John, who's had his liver transplant for over 30 years now. So, any comments about this? If not, then we'll move to the next article. This is an interesting study that identified the role that genetics plays in predicting who's going to get diabetes, whether they're overweight or not. And they did some genetic tests to try to identify whether or not the genetics identifies what causes diabetes more so than and as you know, type 2 diabetes is commoner in people of color, particularly after the age of 40. And this in the past was associated with people who are overweight or obese and did not exercise. So this identifies genetically people who likely become diabetics regardless of the weight and other factors. Whether this will pan out in the long run, this is the first test that has identified this. And so over time, it'll be interesting to see if this data holds up in all ethnic groups as well as in all populations. Whether this is going to be important or not is not as important as the recognition that the role of genetics in the practice of medicine is becoming more and more important. There was a time when genetics was nice to have, but we're getting to the point now where genetics is a very important part of the practice of medicine. And although it has its hazards, genetic tests now play a role in the so-called precision medicine that we're getting into. Any comment about it, particularly as it relates to the fear of people of getting genetic testing? Because I think it's something that
I had a question.
yes,
The genetic testing for diabetes, and I think you said it already, that they will probably do genetic testing for other diseases, like maybe kidney disease.
that's correct. As well as the important role it plays in the cancer. So this is something that we have to come to grips with. Dr. Perez?
I know it was decades ago that we did a study back in, I guess, around the time that the human genome was decoded.
2001.
Huh?
2001.
2001. And at that time, I think the internationally renowned center was there at Howard. And in terms of, politically how that went. But this is the outcome, I believe, of what we aimed for then. To have personalized medicine, to be able to be more specific and strategic with healthcare, going away from a disease model to one that was more that appreciated using genetics for prevention.
Very true. Any other comments about this? Very important. Just like artificial intelligence, genetics is a thing that is going to be with us. And so we're going to have to learn how to make sure it's as unbiased as possible and use it to our advantage, because the scientific world, as well as the medicine world, as well as patients, are going to have to recognize that it is in our best interest to know as much as we can about ourselves and our health, and that the role that genetics plays and artificial intelligence plays will help us to have better health. And as you mentioned, an ounce of prevention is worth a pound of cure. And the criticism of Western medicine is that we spend too much time treating diseases when we should spend much more time preventing disease.
And I cannot remember her name, who started.
Dr. Georgia May Dunstan.
Yes, thank you.
Yeah, Georgia May Dunstan, who
and
has worked with us on many occasions.
And where would we be if racism wasn't involved in the policies and the allocation that Howard received?
Well, it is involved, and it's going to be interesting to see how Howard will be able to survive this threat to its existence.
And just one other point. If you look at the most basic genetic format domain, the closer you are to the original genetic format or the genetic, where we are, you would have to say, since the cradle of civilization is in Africa, that those with the most genetic component structure would be more valuable to all other genetic domains. It's probably a bigger conversation than right now. I'll look to.
I think everything that we've learned suggests that you're quite right. Okay, any other comments? Next article, please. This is an interesting article that talks about a new drug that achieves type 2 diabetes remission, which is something that has happened with caloric restriction and exercise. But this identifies that with this new drug, dapagliflozin, that remission is much more common. The only problem with the study is that this is done in China, and we don't know how its applicability to people of color and in the United States. But this is work done in China, and suggestive that this medication will help in the management of type 2 diabetes, which we suffer from more than most other ethnic groups. It's just information. This study has not been done in our country yet, and so we await its applicability to the United States. But it's very promising, however. It goes back to a point that Lucy had made with other considerations. Is the restriction of weight and exercise alone enough, or do you need medications as well? And so we need to have many more studies to answer that question. Any comment about this before we move on?
Yeah, it doesn't mention anything about this being a GLP drug, so I guess it's
not. No, it does not mention anything about that. Although we're going to see this drug come up in another study, but
Is it
does
an
not.
appetite suppressant?
I couldn't tell that. I couldn't tell from reading this, but there's another article that uses it, and I guess we get some more information from that one. But I couldn't tell whether it was an appetite suppressor or not. This is another drug that is now being used to improve diabetes remission rate. This also is used to decrease renal failure as well. But this is a new drug that also improves diabetes remission. Uh, and you may wonder why all this concern about diabetes? Well, diabetes is a disease that untreated is lethal. Not only is it lethal, it produces so much morbidity, requiring amputations and causes heart disease, kidney disease, brain disease, you name it. So any effort to do away with it or resolve it or get it to go away is worth it. So this is something along with calorie restriction, uh, decreases the likelihood of diabetes uh, coexisting. Although we must admit that with weight reduction and exercise, it also works. But it says that with this inhibitor also, uh, the remission of diabetes does occur. And that's very desirable because you can see it's considered as an incurable disease unless you can overcome it. So therefore, it's worth to have these kind of studies to answer that question. Mr. Buchanan?
Yes, this is the same drug from the earlier article, from the previous article.
Yes, that's right. Yeah, and it doesn't define its mode of action, except that it works, which is what is important. And it apparently is not a glucagon a derivative, so it's separate from the glucagon receptor agonist. It is now very commonly used in the treatment of trying to slow down the progression of kidney disease. Yes, Mr. Buchanan?
Yeah, my question is always to see how much does it cost?
Uh, I don't know, and this does not address it. So we'll have to look it up and see what it costs. Right now, it is used uh, pretty significantly in the treatment of kidney failure, and I know Medicare is covering it, but I don't know the exact cost. But it's a good question for us to try to answer in the future. Thank you for asking that question. Any other comment? If not, let's go to the next article. This is an interesting article that addresses that coffee alone seems to protect you from diabetes. But when you add sugar or artificial sweeteners, this decreases the ability to prevent diabetes. Cream doesn't bother it, but artificial sweeteners and sugar uh, does away with the protective effect of coffee on progression of diabetes. Interesting question, and once again, we come up with the two of the current so-called poisons of the 20th and 21st century, salt and sugar. And so I don't know how many of you are coffee drinkers out there, but so coffee's good, but It's the sugar you add to it that takes away the benefit of the coffee. Some of the benefit, doesn't take away all of it, but takes away some of it. Any comments about this interesting article? I think some people, well, they didn't check about milk. They said cream. So, and it's going to be interesting to see how many studies will confirm this observation. Next article, please. This is about older adults with kidney disease. They face psychosocial barriers in transplant evaluation. And what this means is that navigating the transplant process is much easier for the younger, but for the older person, it may be a little harder. And what we know is that people of color are less likely to complete the transplant evaluation process, which is critical in order for you to get a transplant. So this study looked at those people who were evaluated, and they found that those people who were over 65 were less likely to complete the evaluation than others. And this suggests that the navigation process needs to be more hyped up for the people who are older because it's uh, less easy for them to complete the evaluation process. And so what is recommended now is that transplant programs have more navigators who facilitate and expedite the transplant workup so that they can complete it. One of the biggest problems we've identified and why blacks don't get more donor transplants, that they don't complete the process. And of course, the difference between successful living donor transplant and a deceased donor transplant is about 20%. And also, staying on dialysis rather than having a transplant when you can is less likely to be associated with good outcome with avoiding mortality and avoiding other complications of kidney failure. Any comments or questions about this article, which is emphasizing the importance of the navigation process, particularly for the people over 65? Mr. Buchanan.
Yes, what can you detail the process that you have to go through to determine if you can get a
Yeah, you have to have first you have blood tests to make sure that you have tests of the heart, tests of the GI tract, you have colonoscopy, you have your heart testing to make sure that you will be able to successfully survive the transplant. Then you have to have tests that identify your mental well-being to see if you're mentally fit. Then you have to have sociological tests that identify that you have the support that's necessary to have a transplant. And then you also have to test to evaluate your ability to take the medications or have some support system that will help you take the medication because medications right now in transplantation, once you're on transplant medication, you have to be on them for the rest of your life. So the follow-up becomes critical. And so these are just some of the factors. In addition, in order to get the blood tests, in order to get the heart tests, in order to get all of the tests that are necessary, you have to be present and you have to follow up in a timely fashion to get these tests done. Then after the tests are done, the tests have to be evaluated by a team that will ascertain that you're healthy enough to withstand a transplant and that when you have the transplant, you're a good candidate to be successful. So that's a brief outline of the steps that we require you to take care before you get a transplant.
Is there a time frame on that? How much time do you think it would take to evaluate that?
It all depends on you. There's some people who will be very timely and get it done within 1 to 3 months. And there's
Okay.
some people who they just never get it done. And that's the biggest problem. That's why navigation of the system is something that we need to spend much more time in evaluating, because that's one of the most important reasons why people of color are less likely to get living donor transplants
Mhm.
and to get deceased donor transplants as well. So we need to have something in the system, and the navigation and navigator position is the one that emphasizes getting that done as quickly as possible so you can be a candidate for transplantation. Dr. Perez?
And again, Howard Freeman, one of your mentors and part of that group that you were in, who actually had the policy so that we now compensate in insurance navigators, which is critical in our community.
It's critical in our community, but all transplant centers do not have navigators.
And that's why this group is so important, because we will not stop. We will continue to raise the issue that this is critical. Just as transplant support groups, your research has demonstrated that without them, the outcome is not the same. And so having people, families, and communities that are educated about the things that you do every Thursday morning is the equity.
Thank you. Mr. Tatum?
Yeah, they used to call these people transplant coordinators.
No, no, no,
What do
no,
they
no,
call them
no,
now?
no. Transplant coordinators also facilitate the navigation process, but they have so much more things to do that a lot of times things fall in between the cracks. And so a navigator is somebody who, in addition, who their only responsibility is closing the loops. The transplant coordinator has about 10 to 20 different things he has to do. And as a consequence, they are not completely able to get the navigation process completed for everyone. Whereas if you have a navigator as well as a transplant coordinator, you're more likely to have that process completed for all of your patients.
And my follow-up question is, when it came time for me to have a liver transplant, um, do you remember the names of the people who helped me in that process?
Yeah, Curtis Yeager was the transplant coordinator, and he
Okay.
navigated all of that stuff. As a matter of fact, I was hoping he would join us, but yeah, he was the transplant coordinator, and you're right, that's the chore of the transplant coordinator. But it now has gotten so complex that you need not only to have a coordinator, but you also need to have a navigator, unless you have many coordinators. Mr. Davis.
Yes, sir. Just a question. You were speaking on the age component and what happens as older people go into this process. Um, do we have the racial breakdowns on that by chance?
Oh yeah, we know that for blacks, for example, one of the things that we've identified is that since 2014, the number of living-related transplants have markedly decreased, and so the number of people of color who are getting living donor transplants is markedly reduced. So we need a special effort, and that effort was done actually with the Latino Hispanic population, and it required some financial investment. But with that investment, the Hispanic rates of living donation has markedly increased. And we need something like that similarly done with the African American population, because we know that living-related donor transplants are 20% more successful than deceased donor transplants. And while the rate of African Americans getting deceased transplants has significantly increased, the number of Blacks getting living donor transplants has significantly decreased. And so this is one of the efforts that we at MOTEP are particularly devoted to, is increasing the number of Blacks who get living donor transplants, which means that this navigational process for people of color and people who are over 65 has to be facilitated and increased. Does that help answer your question?
Yes, sir. Thank you.
Okay. All right, I guess going to the next question. This is, seems like we're heavily slated towards diabetes, but that's because when you look at the kidney failure, the number one and number two causes of kidney failure are diabetes and hypertension. And so as a consequence, we are looking at a lot of articles with diabetes. Of course, this is, however, situation in which one of the medications, metformin, is thought to lower the risk of dementia in people with type 2 diabetes. So this article showed that those people who were on metformin, which is one of the common drugs for diabetes, had a lower risk for all-cause dementia. And this didn't particularly look at different ethnic groups, but it did look at groups that were associated with dementia. And so one of the things that we would like to see in the study to let us know what ethnic groups were actually evaluated and whether people of color are appropriately represented in all of this. And that's this was a study that was done in China, so it makes us wonder about whether this is going to be applicable to us or not. But be that as it may, it's something that we can use to try to analyze this here in the United States, since metformin is one of the common drugs that's used in the treatment of diabetes. Any comments or questions as we talk about this interesting subject? And you notice that we talk about where the study was done because it's important for us to recognize that often studies do not include us, and we want to be sure that we're included in the studies so that the generalizations that come from the studies may be applicable to us, may or may not be applicable to us. Now, this is something that is often overlooked. We talk about diabetes and getting control of their diabetes, but sometimes we don't talk about the micronutritional elements, deficiencies of minerals or electrolytes and vitamins. That's when they talk about macronutrition. That's what they're talking about. We often talk about the big things, but sometimes minerals and electrolytes and vitamins are not included in that discussion. And this study has identified that there is a micronutrient deficiency in almost 50%, 45% of the people with diabetes. So that proper nutrition is important for the macro aspect of it, as well as the elements, magnesium, iron, and vitamin B12 and other deficiencies. And so what it's saying is that good nutrition is important for all, diabetics or not diabetics. And so elements, the electrolytes, magnesium, potassium, iron, and other chemical areas and vitamins need to be normalized as well in order for them to have good health. So getting good blood sugar control and not getting your the right amount of vitamins and the right amount of chemical elements becomes an issue that needs to be looked at more closely than we have in the past. So this is a, a, a notion to the doctors and the patients to be sure that you not only getting your vegetables and fruits, but also make sure that you have the right amount of magnesium and iron, etc. Because proper nutrition is just as critical for diabetics as it is for anybody else. Here again, this is a study that was done in India, but it may be as beneficial to us to look into this. Well, these are interesting studies that point out the essential nature of doing some of these studies in our population to try to see if they are applicable to us or not. Any other comments? As this focus on diabetes self-management is important, as we now have these glucagon derivatives that revolutionizing our health, it becomes even more important to focus on proper nutrition. This is something that this group is focused particularly with Darryl emphasizing the importance of proper nutrition, because that's what he's been emphasizing. And proper nutrition is as important as exercise and meditation. And all of these things go together to help us maintain our health. This article doesn't talk too much about the ultra-processed foods, but avoiding them is another part of it as well. Any comments about the very important aspects of this article? One of the things it talks about in this article is cannabis, and there's so many studies recently that have talked about the not so good consequences of cannabis. Cannabis has its medicinal good points, but it also has some side effects if it's abused. Any comments? Any diabetics among us who have any questions or comments about some of this information?
I know one of the areas of the specificity of being racially and ethnically attuned to the population in which you are working with, and all of the studies, all of the policy initiatives to get rid of DEI, which points to all of the things that we say is so very important for a better outcome of all Americans. You know, it's like we know the data, and because of our present administration, we're going in the opposite direction.
Rapidly. We're going in that direction rapidly and trying to eliminate everything that has made us great. Diversity has made us great. And so we're going in the opposite direction, which is something that Trump has long talked about, making America great again, which some people interpret meaning making it white again, which he hasn't said. He said making America great again. So we're hoping that making it great again doesn't eliminate the wonders of diversity which have made America great in the first place. But anyway, that's food for thought. So now this is something that we've talked about before, but requires reminding us that radon levels are still uh, things that occur in your house that you may not be aware of. And high radon levels are linked to some diseases, and one of them is diabetes of pregnancy. And there's a certain percentage of women who get diabetes after they get pregnant. And this data identifies that some of this is because 10% of pregnancies is associated with gestational diabetes, and radon exposure, in addition to causing lung cancer, also causes gestational diabetes. So we need to have our homes checked for mold. We need to have our homes checked for radon as well to try to help us stay as healthy as possible. I don't know how many of you gotten your houses checked for radon lately, but it's food for thought and something that may be worthwhile. As you see here, radon is possibly the most prevalent indoor carcinogen to which human beings are exposed. But many of us are not even getting a radon test in our homes. And so it's something that is worthy of looking into. Betty Baylock.
Yes, good morning, everyone. I jumped up when I saw this article to go look at my radon thing, because after the article some time ago, I did purchase a radon detector, and I just went and looked at it, and it's saying 1.45. So I'm hoping that's good.
Okay, Darryl.
Yeah, some people think they can avoid radon by just staying upstairs, but it circulates throughout the whole house. So, you know, you can't avoid it by just staying out of the basement.
Thank you, Darryl.
And also, it comes up from the ground. So your house is built on the ground. So the radon is going to come up through the building material.
Oh,
My
thank you.
detector is upstairs.
Good. Okay. Well, okay. This is an article we've done before, but I thought it was good to conclude it because it points out that nowadays you can continuously monitor your glucose. And why is that important? Because we like sugar. And since we like sugar, one of the ways of controlling your weight is decreasing the amount of sugar or eliminating it. And this is what this lady thought would be a good idea to keep her from gaining weight. And what this doctor is suggesting is that maybe this is what we should do, because the sugar is what's causing the increased insulin resistance. And if we monitored our glucose, maybe we'd eliminate that as an issue. Of course, if you want to look at it from a different perspective, just eliminating sugar would do it. But anyway, those of us who are addicted to sugar may want to consider this as a way of decreasing the amount of sugar, if not eliminating it. Any comments or questions about some of the interesting points that this article brings up about the importance of vegetables and fruits and avoiding sugary foods, which, as we mentioned before, they point to sugar and salt as two poisons of the 21st century. Any other comment about this very interesting article? Now, this is an article on cervical cancer screening, which is an update to remind us that HPV is the cause of 95% of cervical cancers. And so if you have HPV vaccination, you can eliminate cervical cancer. Also, they talk about now self-tests that you can get to So if you don't want to go to the doctor to get a pelvic exam, you can have a pelvic test screen done. Of course, the best advice is to have this test done elsewhere. But if you refuse to do it, then one of the ways is to do it yourself. Those who are regularly screened and after 65 does not need a PAP exam if you've been regularly screened. That does not mean you do not need to have a pelvic exam. It just means you do not have a PAP test for cervical cancer. But as you know, cancer of the uterus and ovaries still remains an issue. And therefore, because you're over 65 does not mean as a woman you do not need to have a pelvic exam anymore, because you do. But the HPV, of course, is something that is, we want all children to have, males and females as well. This is an article that just talks about the early stage cervical cancer can be cured best by having a modified laparoscopic radical hysterectomy, which is now available. I won't go into any more detail on this, just to say that this is something that you and your doctor can discuss if you have cervical cancer, but it's not curable. There's another article that talks about other ways of addressing the managing of early cervical cancer. This is an interesting article that is a challenge in cancer today. Should the term curing cancer be used? One of the things that has bothered me for quite some time is to see patients who have had breast cancer and they're free from breast cancer for 5 years. And they think they're cured. And then somewhere between 5 and 10 years, they have recurrence of the disease. And so it makes you wonder, should we say free of disease or should we say cancer? Most people would agree that after 10 years, you might want to use free of disease, but cure, that's a term that I think if you're not 10 years beyond cancer, it's difficult to say you're cured. You can say you're free of disease, but very often some of those people who are free of disease come down from cancer, recurrent cancer, before the 10-year period occurs. And so this article is wondering whether or not we should say free of disease or should we say can't cured. What are your thoughts about it?
Dr. Callender, my thought is I noticed that women, the Black women, have a higher incidence of this, so that they have parties after the cancer is removed. They celebrate. And so what this article may be saying is that the celebration may be premature.
That's what it's saying, and that maybe after 10 years might be a better time. I personally have had a couple of my colleagues who were free of cancer at 5 years who died of cancer a year later, so that I'm wary of the term cure and think cancer-free might be a better term. After 10 years, maybe, but before then, it's a question mark to me. Mr. Buchanan.
So if, Dr. Callender, if someone has been treated successfully for, say, skin cancer, and is it more likely for a different cancer to show up? I'm just talking about, they say cancer, they don't say a specific cancer.
Well, skin cancer is different from many other cancers, and it depends what kind of skin cancer you have, because melanoma is very different from uh, basal cell cancer, which is different from squamous cell cancer. So skin cancer is not thought of in the same terms as the solid organ cancers. And so there are certain skin cancers that are more common, more likely to recur. As we said, melanoma is a skin cancer, which is very likely to recur.
My my my
Squamous cell
question,
cancer is a skin cancer, which is capable of recurrence. Uh, so that skin cancer is a little different, but it depends upon what type of skin cancer you have.
my question is more the generalized term cancer, because cancer can be in all different kind of parts of your body. If you are treated for one of those types of cancer successfully, is it possible or more likely for a different organ to have cancer, or a different part of your body to have cancer?
Yeah, that's always the case that because you have cancer in one part of your body and it's cured, it does not mean that you cannot have cancer in another part of your body. So I guess the answer to your question is that yes, you can have cancer from more than one location.
Dr. Callender, I can't raise my hand, but a question. The word cured, does that mean that it's eradicated, or it just means that it's in remission?
That's what this article is all about. And it's saying that if you're 10 years removed from it, it is likely to be a cure. If it's less than that, then it's a question as to whether or not it's in remission or whether it's cured. So, and it is suggesting maybe that 5 years is too soon to say that it's cured. You're free of the disease, but whether it's cured or not is another question. Does that answer your question or further?
Is there any way to say that, okay, what does cure mean? That it doesn't occur again, or you can actually look and say you are cured, this like chicken pox, you no longer have chicken pox?
Well, that's what the whole article is about. It's saying that cure is not a good term for cancer unless you're 10 years free of the disease.
Okay.
Dr. Perez?
I think it's important for us to appreciate the mental health of people going through the procedure. I know following radiation or following chemotherapy, there is a celebratory time where people ring bells, and I think all of that is helpful moving forward. But I think the psychology, where people are emotionally, is critical to the team moving forward. Some of us can celebrate small baby steps, so to speak, and knowing that you haven't passed a significant hurdle can impact how optimistic you are about moving forward with nutrition and other strategies to get to wellness. So I think this information, along with the counseling that goes along with the chemotherapy, would be very, very important. And I think cultural beliefs and understanding need to be interwoven here as well.
Darryl, you had a comment?
Yeah, Dr. Perez was talking about the psychology of it, and I think that the patient is better off, especially in cancer, not celebrating a cure, but just going free from disease. Because I think the temptation is when you say cure, then you think you're free to go back to the old lifestyle, which may include an inflammatory diet, which may trigger another episode of cancer. So, if you're free for disease with the caution that you have to maintain that lifestyle that you took while you were getting treatment, then it's more likely to keep you free from disease longer than, um, recessing back to a harmful lifestyle.
Thank you for that comment. Mr. Tatum? Ms. Thomas, yes?
Yes, I have a
Yeah.
comment.
Catherine Thomas?
Yeah, I have a comment. Yeah. In my brother's case, he had cancer, esophageal cancer. And the doctor came out of the surgery and he told the family that he got it. I got it. Which means what meant to us at that time that the cancer was benign and it was localized in one place. And he did the surgery and removed that benign cancer. And that's why.
There's no such thing as benign cancer.
Okay, well, he said, well, I don't know. He said, I got it. What did he mean? And he said, I got it. I got it out.
What he meant was that he got all of it that he could see. Right.
Okay, thank you.
And I think when you take out the cancer, you may or may not know whether it has spread before you took it out or not. And if it has spread before you took it out, then you may think you've got it, but you really haven't. Does that address it, or go on and finish your comment?
Yeah, that does address it. And then I don't think he should have used that expression, I got it. He should have said something else.
Yeah, I think that and that's the issue with cancer and the proclamation of cure, because it may give you false hope. Darryl's perspective is the great one that and might be better mentally to look at it from that perspective. This is the last article I'll be able to do, and what it's all about is that cancer is shifting to younger adults and women more than men, and this is something that is frightening to some degree. There's overall decrease in cancer mortality, which is the good news. The bad news is that Native American and African American populations still have 2.5 times the incidence of cancer than the white people do. And we're not doing well with pancreatic cancer at all. But the shift to women and younger people is something that is concerning. That means we need to look earlier to make a diagnosis and treatment and find ways of developing healthier lifestyles so that we don't get this inflammatory disease that we call cancer. Any other comments? Because this is something for us to take note of. Increasing cancer rates in women and younger adults. Darryl?
Yeah, as population, especially the younger population, is much heavier. And with the obesity, that's probably triggering the cancer.
Yeah. That's not very something that people would like to hear you say, but it's true nonetheless. Dr. Perez?
And the other issue, this is a population with less political clout. So it is important, just as, I'm pushing the issue of DEI, but we saw the breakthroughs because we had women involved. And now we're seeing that women and children don't have political clout. that we have to carry the water to make sure that we continue to have those strategies and research that addresses these issues.
Well, the new administration is eliminating those things. So what are we to do?
Rise up. Got to rise up. You know, we've been here before.
Okay, all right. It's clear that the administration is laser focused on doing exactly what you said they are trying to do, and I agree with your feeling about it. That if we don't demonstrate that this is something that we feel is a priority, the administration will do everything in its power to eliminate what has become a major strength.
We've got to be Dr. Callender's that spoke to transplant boards and said, no, my people will be included. They will go on the list, despite the fact that for all the things that you have done, you know, to make people change because you were at the table. We have got to make sure that that continues.
And we have to stay at the table. I think that's a very good point. And I